We are live.
Okay. Good evening, everyone, and welcome to iFocus Online, India's best online PG teaching program in ophthalmology. This is episode number 399 and the 13th episode in the iFocus Cataract module. And today we have our chairperson, Dr. Kamaljit Singh, sir, and the speaker for today would be Dr. Subodh Sinha, sir. The topic would be small incision cataract surgery types, basic principles and steps. This is a very, very important topic, uh, both from a PG's point of view as well as from a practical point of view. And I'm sure sir is going to deliver an excellent lecture, and a lot of insights will gain from this today's topic. So, Dr. Kanika, how do we start?
Okay, sir, I'll just take 2 minutes. I welcome all of you to this episode of Dr. Amit already said is a very important topic for the postgraduates. I would like to welcome Dr. Amit Pandey, sir. He's the moderator for today's session. And Dr. Amit is a senior consultant in glaucoma, cataract, and refractive services and is presently working at Center for Sight Surat. His name knows no introduction. We all know he has many firsts to his brilliant career list, and including first eye stent implant, first Oculus gonio ready use. Even in the state of Gujarat, he was the first surgeon to implant an eye stent. And I have personally seen him conduct so many of these workshops all around India. And not to mention, apart from this excellent uh, uh, CV that he has, he is also an excellent mentor and a very humble person and very down to earth. Sir, it is a privilege that you are moderating this session. Over to you, sir. We have our chairperson, Dr. Kamaljit, sir. He is also a senior consultant. I welcome, sir. And Dr. Subodh Sinha, sir. Again, both of their names, they don't need any introduction, but over to you, Amit, sir, for their introduction, sir.
Thank you. Thank you so much, Dr. Kanika. Let me first introduce the chairperson, Dr. Kamaljit Singh, sir. He's a professor and head of department of ophthalmology department in MLN Medical College, RIU Allahabad. So Professor Kamaljit has many books published in his name, including today's topic, small incision cataract surgery, which was published in 2002, and the second edition came in 2008. He has been awarded the WHO Fellowship, is a past president of IRSI, vice president as well, vice president of UPSOS. He has held a lot of important positions. He is a chief editor in ophthalmology and allied sciences since 2015. And he has performed a lot of live surgery demonstrations, as well as he has been a guest speaker, national and international conferences with several research papers to his name. He's also given many orations at IRSI, at UPSOS, Bihar SOS as well. So we welcome Professor Kamaljit Singh, sir, to this iFocus online. So with your permission, sir, I'll also introduce today's guest speaker, Dr. Subodh Kumar Sinha, sir. Sir has done his MBBS from Darbhanga Medical College in Darbhanga and MS Ophthalmology from the Institute of Medical Sciences, BHU. He's also done an MSc in Community Health, Eye Health from International Center of Eye Health in London School of Hygiene and Tropical Medicine in London, and also a fellowship from Arvind Eye Hospital, Tirunelveli. He's been a consultant, a past consultant at Venu Eye Institute from 98 to 2013, and since the last 11 years, he has been with Center for Sight as a cataract, glaucoma, and refractive surgeon. Is involved in teaching and training programs of ECC, SICS, and FACO training for DNBs and fellows. and he has worked with NPCB and state blindness control societies to establish eye care services in Arunachal Pradesh and Bihar. Uh, he has also been involved in facility survey in eye care services in North Korea as well, and helped in development of guidelines of cataract management in Sight Savers International. So, sir is an excellent choice for this today's topic. And with your permission, Kamaljeet sir, Singh sir, I'd like Subodh sir to start the today's session. Thank you.
Yes, please, Dr. Subodh, you can start. Thank you.
Thank you, Dr. Amit. Thank you, Kamaljeet sir. I will straight away start I will going to share my screen. So basically, as you know, nowadays the three most commonly performed cataract surgeries are phacoemulsification, which is the gold standard nowadays. But the other surgeries which is most commonly performed for cataract is manual small incision cataract surgery and extracapsular cataract surgery. Extracapsular cataract surgery is becoming less and less popular, but manual small incision cataract surgery and phaco nowadays is being performed most commonly all over the world. If we compare the traditional extracapsular cataract surgery with manual small incision cataract surgery, the biggest advantage of manual small incision cataract surgery is the wound is self-sealing and it can be done without any suture also. Particularly in developing countries like India, where the resources are not uniformly distributed, and certain areas where we don't have access to advanced techniques of phacoemulsification, manual small incision cataract surgery has definitely a good choice due to the reason that it has shorter operative time, less need for technology, and lower cost. So if we look at the history of cataract surgery, this technique, manual small incision cataract surgery, was introduced in early 80s. I think it's the same time when we also started fine-tuning our phacoemulsification techniques also. So 1983, Richard Gras was the first surgeon who moved his incision from limbus to sclera. The idea was to increase the surface of a closed wound, and which leads to enhanced wound healing and less astigmatism. Girard and Hoffman, 1984, they coined this term scleral tunnel incision. Later on, Jack A. Singer, he modified this incision in a shape which is frown incision, frown to the surgeon, and the purpose of this incision was to reduce surgically induced astigmatism. Next was Paul Ernst, who introduced the concept of internal corneal lip. Basically, uh, this was done to make a valve which imparts self-healing properties. Later on, Paul Koch described the term of the concept of incisional funnel. if we look at the limbus of this patient's cornea, now we can see there are two imaginary lines, these are the two imaginary lines, which is approximately 3 millimeter at the limbus. From there, it is diverging, and he introduced the concept that any incision, if you make in between these two lines, it will be causing least astigmatism. So this means that if you are making an incision, if it is anteriorly, it will be smaller compared to if you make it posteriorly to have the same amount of astigmatism. So for the technique of MICS is concerned, if you want to do surgery, it can be done under peribulbar anesthesia, it can be done under retrobulbar anesthesia, it can be done under subtenon or topical anesthesia with intracameral lignocaine. But for the beginners, it is discouraged to do under topical anesthesia, particularly for the beginners and particularly for the situation when you anticipate difficult surgery. So the next step is the use of bridle suture. Bridle suture, again, if you are planning a superior incision, you can take a superior rectus bridle suture. If you are planning a temporal incision, which is becoming more and more popular, you can take lateral rectus bridle suture. Some of the surgeons who are doing temporal incision, they don't take any bridle suture at all, but it sometimes helps, particularly fixing the globe or while implanting the lens while taking out the nucleus. It sometimes helps. But there is one basic difference between the two bridle suture. If you pull the superior rectus bridle suture, since the superior orbital margin acts as a fulcrum, the globe is turned down. That doesn't happen with the lateral rectus bridle suture. Because if you pull the suture, there will not be any brow effect, and the globe, rather than going easily, it may move temporarily. So these are two. Here we are taking two pictures. First one, we are taking the superior rectus bridle suture. Here we are taking the temporal lateral rectus bridle suture. Okay, so although it looks a very easy step, but should be slightly cautious. The advantage of bridle suture, it holds the globe steady. So while performing peritomy and making sclerocorneal tunnel, the globe is steady, so it makes the things easy. It also helps during the nucleus delivery. IOL implantation, it gives better exposure, and sometimes you can take both superior and inferior rectus muscles, particularly in a condition where there is deep set and small eyes. Because taking both bridle sutures, it will lift the globe and it becomes more prominent. So one of the complications which may happen at the time of bridle suture is globe perforation. So you have to be a bit careful, because the important thing is to do everything under microscope observation, and you take the small bite of the muscles, lift it slightly, and then always look at the tip of the needle, which should be directed upward, and take only a small bite. Don't take a bigger bite. That may lead to increased risk of globe perforation. Now, what will it do if there is perforation, globe perforation? The moment there is globe perforation, the eye will become soft, And if you suspect perforation, the best thing to do is stop the procedure and try to view the possible area of perforation by indirect ophthalmoscopy. And if there is any, you see any evidence of perforation, take the help of your retina colleague. And if the cataract is not dense and the damage is accessible, then they can do laser or cryo. But if the cataract is too dense, then you have to perform D-scan to find out if there is any vitreous hemorrhage or you find any evidence of perforation, and then you can manage accordingly. The other things which may happen at the time of taking brittle suture is bleeding or subconjunctival large hematoma, injury to the rectus muscle. And if you are not very careful while taking the superior rectus brittle suture, there may be some trauma to the LPS muscles, which may lead to postoperative ptosis. Next step is the conjunctival peritomy. We in small incision cataract surgery, we only do Fornix-based conjunctival flap. Then we should do very gentle cautery. Don't over cautery the area, and particularly avoid the limbal blue zone bleeders that may lead to increased astigmatism after surgery. Always do cautery after you have removed the Tennant's fascia sufficiently. If you don't do it, then removing it later will be very difficult. Once you have made the scleral incision and tunneling, cautery should not be applied, because if you do that, there will be fish mousing and wound leakage, and you will require suturing. So the problem with excessive cautery may be scleral thinning and scleral necrosis and poor wound healing. This is further compounded by the fact that the sclera is relatively avascular tissue, and post-operative steroid use may lead to delayed healing. So one of the common mistakes which we do at the time of doing SICS is that if we do excessive corneal dissection like this, it may lead to poor hold during surgery, and after surgery there may be difficulty in approximating the flap ends. So it should be just enough so that you can make a appropriate size tunnel. Now, if we look at the surgical limbus, surgical limbus is this area where you have anterior limbal border, posterior limbal border, and the anterior limbal border is the area where the conjunctiva and Tennant's capsule is inserted into the peripheral cornea. It is the same place where the Comens membrane terminates. If you look under microscope, a zone in clear cornea where the fine conjunctival vessels are terminating is the same area as the anterior limbal border. Mostly while doing phaco and maybe sometimes manual small incision cataract surgery with phaco fracture techniques, we make corneal or anterior limbal incisions. You have to be very careful because there will be some chances of decimate stripping. You are using blunt instrument or not very careful while doing it. So behind this anterior limbal border is the blue zone, which is posterior to it and is around approximately 1 millimeter superiorly. It under microscope, it looks as bluish translucent area after dissecting the overlying conjunctiva and Tennant's capsule. Mid-limbal line is the junction of blue and white. This is the white area and this is the blue area. So the junction of it is the mid-limbal line. It overlies the Solves line, which is the termination of the decimates membrane. It is the preferred site of incision. Now, white zone, it starts at mid-limbal line. From here, posterior to it is the white zone, which extends around 1 millimeter and terminates at the posterior limbal border. It overlies the trabecular meshwork area. you have to be careful at this incision at this side, because if you're doing giving incision at this side, it may cause damage to the trabecular meshwork. Then there is a posterior limbal border which overlies the scleral spur or iris root, and incision at this side you have to be careful, because this may lead to excessive bleeding and hyping. So now there is the concept of astigmatic neutral funnel. Here, if you look at the different dimensions of the tunnel, and this is the length of the tunnel, this is the width of the tunnel. So surgically induced astigmatism is directly proportional to the cube of length of incision. More the length, there will be more surgically induced astigmatism. Whereas it is inversely proportional to the distance of the incision from the center of cornea. So more width means less astigmatism, more length means more astigmatism. Now the shape of incision, again, it can be frown incision, frown to the surgeon, it can be smile like this, and it can be straight. And if we look at the surgically induced astigmatism, different studies say that frown incision have less astigmatism compared to more astigmatism in convex incision, followed by less in straight and minimum in frown incision. This is due to the fact that the sagging of the wound is less in frown incision. Incision of 3 to 3.5 millimeter at limbus results in minimum astigmatism, so it can be considered as astigmatically neutral for all practical purposes. Smile incision, while it is easy to make, but it is having more astigmatism compared to frown incision, while difficult to make and minimum induced astigmatism. The other incisions, one is the Blumenthal side cut incision. Here you are making a straight incision and then making two side cuts, radial side cuts. This will help in the creation of side pockets. And Chevron V incision is the incision like this, a V-shaped incision, which is difficult to make, and the maneuverability of the different steps, it becomes more difficult, but it has least or nil astigmatism. Now the site of incision, if we look at the temporal incision, it makes the access to the surgical zone easy, because it's not obstructed by the orbital edge of the frontal bone, or minimizes the effect of the Bell's phenomenon. At the same time, since the horizontal meridian of cornea is more than vertical meridian, this site of incision will lead to less astigmatism, and also it makes the red reflex more red reflex, that helps in some of the intraocular steps. And you can sometimes manage without brittle suture, particularly when the nucleus is not that hard. And temporal scleral incision, the drawback is that it is cosmetically not that acceptable, and at the same time, theoretically, there are more chances of having post-operative endophthalmitis. Superior approach is useful in situations where you want to reduce the pre-existing with the rule astigmatism, and sometimes I find when you are having your vitreoretinal colleague there and you anticipate some intraoperative complication, they are more comfortable with your superior approach, because they have more areas to do manipulation. And the studies show that definitely the superior incision will have more astigmatism compared to temporal incision. Oblique incisions can be given when you find there is oblique astigmatism, then you can keep incision on the steepest meridian. Position of the incision, you can have corneal, limbal, scleral, sclerocorneal. As we already seen that the more you move away from clear cornea, there will be less astigmatism. Corneal incisions, it is very useful in situations when you are doing phacoemulsification, because that you can do under topical anesthesia, and aesthetically it's very good result. And it is quicker, faster, less chances of bleeding, particularly those patients who are on anticoagulants, and there are decreased risk of iris prolapse and epithelial ingrowth. And at the same time, there are less chances of formation of peripheral anterior synechiae. So we are more concerned about the sclerocorneal incision in manual small incision cataract surgery. So if you look at the dimension, this is the length of the incision, which we decide on the basis of the size of nucleus, and the if we find that the nucleus is not that advanced sclerosis is not there, then we can plan for 5 to 6 millimeter, particularly for cortical cataract. But advanced sclerosis like grade 4 nucleus, you may have to go for a bigger length of incision. And also in case of compromised corneal endothelium, go for a larger size so that your nucleus delivery is smooth and there is less damage to the corneal endothelium. Next dimension is the scleral, is the depth of the incision. As we know that scleral thickness is around 0.6, 2 millimeter posterior to limbus. So incision depth can range from 1 millimeter to 5 millimeters. It's don't go for the extremes like 0.5 or 0.1 or 0.5, that may lead to problems. There were guarded calibrated diamond knife available, but you can, over a period of time, you can have good idea about the depth of the incision, and you don't actually need it. If your depth is less, it may lead to thin flap, which may lead to buttonhole formation. And suppose there is a buttonhole formation on one side, then you can start from the other side. If it is on center, you have to either abandon that area, or you can and go to the other, or you can even try to do a dissection at a deeper plane. If your flap is very thick, means you are going very deep, this may lead to premature entry or damage to the scleral spur and ciliary body. Width of the incision is the distance between the external groove and internal entry. It should be approximately 4 millimeter in size, because you are going 1.5 to 2 millimeter into the cornea, and you are making incision around 2 millimeter behind the limbus. So approximately 4 millimeter in size. Wider the flap, there will be less astigmatism, but that may lead to more bleeding and difficulty in manipulation. So the essential elements of a sclerocorneal tunnel is your external scleral incision, which you make with the help of a blade or surgical knife. BP blade number 15, number 11, you can use any of these three. Sclerocorneal tunnel you dissect with the help of crescent knife, and internal corneal incision is made with keratome. So while making the sclerocorneal tunnel, you need to remember certain points. Scleral cauterization before tunnel construction, that will reduce the risk of pre and post operative hypemia, but at the same time remember that don't do over cautery. You have to remember that eyeball is a globe. So whenever you are doing this dissection, you have to orient your crescent in the upward direction toward this towards the dome of cornea. If you go straight, then there are chances that you may do premature entry and the whole thing become very messy. At the same time, you have to remember, while you have just crossed your sclera, the maximum resistance will be at limbus. So if you have to be careful while you are going from limbus to cornea, because sudden resistance is lost and you may lead to premature entry. So you have to adjust your force accordingly. Again, the cornea is steeper than sclera. So after entering the cornea, your direction should be further away, further anterior. So you have to remember that you heel of your crescent blade that touches the globe that time. So once you have dissected 1 to 2 millimeter into the clear cornea in front of the vascular arcade, then you have to create a side pocket. Here we are going sideways to create a side pocket here. So approximately 45 degree can do that. You have to remember that your internal opening will be bigger than your external opening. So you are actually making a funnel. So once you have dissected, you have done the corneoscleral dissection, then you have to introduce keratome. While introducing the keratome, you have to be careful. For the beginners, it's better, you can, if you want to be extra safe, you can put some visco inside this dissection so that your entry of the keratome is easy. Once you have reached the anterior end of the tunnel, then you have to change the direction of the blade so that you can see a dimple on cornea, and then you can enter into the anterior chamber. Once you have entered into the anterior chamber, then your blade should be parallel to the iris, and then you start making internal opening on both sides. You are cutting the internal opening on both sides. You have to remember that while you are making an internal incision, the movement of the keratome should be lateral and anterior, not lateral and posterior, so that the valve action doesn't lose. Always remember to avoid blunt keratome that may lead to stripping of the decimates membrane. So this is the video which this case I did recently. This was a case of this was a brown cataract with poor endothelial count, and the pupil was not that much dilated. So we are doing temporal SICS to rule out to negate any with the rule against the rule astigmatism. So we are doing temporal incision here. So this is almost straight with two side cuts on both sides. For a cataract like this, you have to make a side port, this side pocket, both sides. We are going 1 to 2 millimeter into the cornea. After making this incision, we are going ahead with the rhexis part. It's always better to stain this type of cataract so that your rhexis is, you can easily visualize your rhexis. making a curvilinear, continuous curvilinear capsular axis. Making a small relaxing incision. Now the internal incision. Once you entered, your movement will be from like this or this side like this. So some of the problems that can happen, ballooning of conjunctiva is more common with the conjunctival, and staining of the tunnel sometimes happen. The blood trickles into the tunnel, and that mostly helps. Premature entry, if your tunnel is too deep, and that makes the incision non-self-sealing, and that may lead to shallowing of the anterior chamber, iris-stoma, and iridodylisis. So this type of situation, it's better to secure the wound with 10-0 nylon and go to a new site. Calibrated angle blade may help initially because you have better idea of the depth of the incision, and entering the anterior chamber after injecting sufficient viscoelastic, and blade should be angled upward while making the tunnel. That also helps. Now, one of the common mistake which we do at the time of manual small incision cataract surgery is, instead of trapezoid configuration, we make a bottleneck type of this type of incision, this type of colonioscleral tunnel making. Why we haven't created any side pocket on both sides, so this may lead to difficulty in nucleus delivery. And if you try to forcefully try to deliver the nucleus, it may lead to iris prolapse and PCR. So it's always better to make side pockets, so that makes the nucleus delivery smooth and safe. Internal incision, while making internal incision, if you try to give internal incision obliquely like this, and again this may lead to triangular inner lip, which loses the self-healing property, and that may lead to wound leakage. So it's better to keep your keratom straight, so that your internal incision is parallel to your external incision and the self-healing property is retained. While making this corneoscleral tunnel, you should not apply too much force with your dominant hand. That may lead to collapse of the anterior chamber at the time of making internal incision. So next step is the capsulotomy. Capsulotomy, you can do a manual small incision cataract surgery with any type of capsular opening. That is the biggest advantage of manual small incision cataract surgery over phaco, that even if you are not able to make a CCC, still you can go ahead with either cane opener or linear capsulotomy. CCC, while making CCC, although it's a good technique because it makes the hydrodissection and in-bag rotation is more safe, and the centration of the IOL post-operatively is better. There are less chances of PCO. In case of PCR, you can go ahead with IOL implantation and optional optic capture. And but you have to remember that your CCC opening is large enough for the prolapse of the nucleus. Can opener capsulotomy in a situation where the large nucleus is there, as in brown cataract or black cataract. In case of Morganian and intuition hypermature cataract, you can also do safely with envelope capsulotomy, which again has the advantage that you can put the lens in front of the anterior capsule in case of any PCR. Raxis, this universal precaution is that your anterior chamber is well formed, That helps better control and prevents peripheral extension of the rexis. Then the next step is nucleus delivery. The nucleus management, which has two steps. One is prolapsing the nucleus into the anterior chamber and then delivery of the nucleus through the scleral tunnel. You have to remember that these two steps, you require a lot of manipulation anterior chamber. So you should use plenty of viscoelastis to prevent any endothelial damage. Nucleus management, the first step, nucleus prolapse, then you can do either hydroprolapse, viscoprolapse, or you can use SICS hook, which can be single or bimanual method. So if you are doing hydroprolapse, you have to put the cannula under anterior capsule perpendicular to the rexis margin, and then you inject a bolus of fluid. What will happen then? The opposite pole of the nucleus will lift. So once that pole is lifted, you can start rotating from that side. You can do cartwheeling or tiring out. And for a immature cataract, cortical cataract, or when the nucleus is not the advanced sclerosis is not there, then it's a very easy technique and it's a very ideal for this kind of cataract. But only thing is that you require a large size capsular system. So here we have injected the fluid here and this pole has lifted. So then you use the hydrocannula to tire out the whole nucleus from this side. You can use, instead of hydro, you can use also visco. But if the nucleus is moderate to hard, you will require single or two Sinski hook to dial out the nucleus from the bag bimanually or using a single hook method. So here this one Sinski hook is used to prolapse, and here you are using two Sinski hook. One is supporting the nucleus, other is rotating and tiring out. So bimanual method is very useful in mature and brown cataract, myopia, pseudoexfoliation, jugular dehiscence, and moderately dilated pupil where you support the nucleus. So this is one video which is I got a very nice video from Arvind, which is showing different types of nucleus prolapse method. This is the hydroprolapse. You are putting the cannula here. You are injecting the fluid. And you can see the nucleus is prolapsing from this side. Another technique is hydroprolapse or intracapsular flip. You are injecting and flipping the whole nucleus. Although this looks very simple, but not good for the beginners. For a hard cataract, you require a Sinski prolapse. Here you are using two instruments. One is retracting the iris and capsule from here. Second one is pushing the nucleus opposite side. Here we are supporting the nucleus with this instrument and rotating with the other instrument. This is another video which this patient I operated few months back. So you can see sometimes it's not that easy, particularly if the nucleus is very hard, and obviously the bimanual technique could have been better for me, but somehow I managed to do with single Sinski hook. So I am trying to do hydroprolapse. That is not happening at all. Then we tried with Sinski hook. Managed to take out one pole. But again, the other part, finding it difficult to prolapse the whole nucleus. Here you have to be a patient, use plenty of visco, and then repeat and again do it. Now it has come out. Now trying to deliver the nucleus with visco expression, and also using the capsulotomy needle to take it out. So you have to be careful about the size of the rexis. As we know, the lens dimension is 9 to 10 millimeter, and the thickness is 4 to 5 millimeters. So you have to plan accordingly. If your axis is small, you may lead this. You tried multiple forceful attempts, then that may lead to jonular dehiscence because you are causing a lot of stress on the jonule. Okay, now once you have prolapsed the nucleus into the anterior chamber, then the next thing is how to deliver the nucleus. So you can do by hydro expression, which is by Blumenthal technique or irrigating vectors technique. You can do visco expression. You can use two instruments in sandwich technique, and there is very popular technique in Nepal, that is Hanig's Pisuk technique also. So Blumenthal introduced this technique of Mininook way back in 1990s. He introduced the concept of AC maintainer. One of the beauty of this surgery is that you can perform without the use of OVD because AC maintainers maintains the anterior chamber throughout the surgery. So here is that once you have subluxated the lens into the anterior chamber, you introduce a seat glide below the upper pole of the nucleus up to 1/3 of the way. Then start pressing the seat glide and that nucleus is engaged in the tunnel. Once it is engaged into the tunnel, you increase the bottle height to up to 70 centimeter, and the hydrostatic pressure is built up inside the anterior chamber. Then you start pressing on the glide. That will cause the nucleus to sever from the epinucleus, and it will mold into the tunnel. Same technique can be used to expel the epinucleus. So this is the SE maintainer, which you have inserted at 6 o'clock position. Once you have prolapsed the nucleus, you introduce a seat glide, and then you press it, raise the bottle height, the nucleus will come out. Another technique is use of irrigating vectors. So while taking out the nucleus with irrigating vectors, there are so many forces acting simultaneously. One is the internal hydrostatic pressure. By the irrigating vectors, you are injecting fluid inside the anterior chamber. The same time you are taking out the irrigating vectors out from the eye, so there is mechanical pressure also, mechanical traction. You are pressing the posterior lip. You can fix your globe with a forceps also, that acts as a counterbalance. So this technique, after you have prolapsed the nucleus, you put OBD above and below the nucleus. Before introducing the irrigating vectors, the common mistake we do is we don't check the patency of the irrigating vectors. That should be always be done. Then vectors without injecting the fluid. While introducing the vectors, don't inject any fluid. Then you follow the curvature of the posterior curvature of the nucleus till you have introduced the vectors, which is now above the iris inferiorly. Be careful here, don't go behind the iris. That may lead to iridodylisis. And even in the very advanced cataract, you can see the vectors. You can see the margin of vectors all the time. Then once you have engaged the nucleus, you should withdraw slowly without irrigating, just to engage the superior pole of the nucleus in the tunnel. And then you pull the bridle suture, and fluid, once the nucleus is engaged in the tunnel, then you start injecting the fluid that will build up hydrostatic pressure. Once the maximum diameter of the nucleus has come out, stop any irrigation and then simply come out. So always check and see the margin of the vectors every time. Don't go so much into the inferior angle. You can manage without even engaging the nucleus here also. So another technique is that once you have a big nucleus and it is engaged into the tunnel, you can simply lift the vectors, and that may break the nucleus inside the tunnel. Inside the tunnel, since the nucleus is inside the tunnel, it causes less damage to the endothelium. Or you can use any sharp instrument like the cystosome to chop off the nucleus, or Sinskey hook. So then you push the nucleus into the anterior chamber, then reorient the direction of the nucleus, and then that becomes small and you can take out easily with the vectors. One of the mistake is that you don't visualize the vectors at the time of while going behind the nucleus. You can see this is a black cataract, still you can see the vectors. So you just look where your vectors is. Then the another technique is the phaco sandwich with Sinskey hook. Your vectors, you can put the vectors behind the nucleus and you can engage with Sinskey hook. So it's a kind of sandwich one, a modified sandwich one. You are supporting the nucleus both behind and anteriorly. So here your vectors is behind the nucleus, your Sinskey hook is in front of the nucleus. Use plenty of viscoelastic, particularly in this type of technique, so that your endothelial damage is less. You can simply use visco expression, which is safe in the sense that your damage to the endothelium is less, and while injecting the OVD, you should always simultaneously press the floor of the tunnel so that the nucleus comes out easily. So this is the Fisuk technique. This Fisuk is made of 30 gauge needle. It has two bend, one here and one this side. Also, one of the video which I got from Lahan. This was introduced by Albert Hennig in Lahan Eye Hospital, Nepal, and the OVD is injected behind and in front of the nucleus, and then you introduce the fish hook. The sharp tip of the needle will be facing on the right side, once into behind the nucleus. Then you turn it up and pull it back. This is the technique which they are doing. So this is the keratom they are using to make all the steps of the tunnel. And this is the fish hook. It has one bend here and one bend here. As you can see, they are using just one instrument to make everything about the tunnel making. The same blade is used to make a linear capsulotomy also. Now they are introducing this hook and taking out the nucleus. You can see it engages the nucleus. Different phaco-fracture technique were designed, and like different type of trisector, dissector, and the common in all these techniques where they were introducing one vectis behind the nucleus and different type of trisector, dissector to chop to divide the nucleus, and but one of the problem with this kind of techniques where the loss of endothelium was significant. Mostly you can see a lot of patients with corneal edema postoperatively. So now is a new technique which has been introduced, that is my loop technique. Here this is a nitinol this is the nitinol thread which can be used to divide the nucleus inside the bag itself. So you introduce this into the anterior chamber and go behind the rhexis margin, and since it is self expandable, you can easily expand this, and this goes behind the nucleus itself, and then you can retract this nitinol wire so that it divides the nucleus and at the same time prolapses into the anterior chamber. So this looks a safe technique compared to the earlier phaco-fracture techniques, since this technique is dividing the nucleus in the bag itself. So another thing is that cortex aspiration, always be careful that don't press the posterior lip while doing IA, and at the same time be careful about cortex aspiration, that you don't hold the cortex at the posterior edge. You try to hold it from here and then take it out like this. Don't go to the near the posterior capsule, that may lead to rupture of the posterior capsule. IOL, always be careful while dialing the IOL in a collapsed bag, that may lead to zonal dehiscence and PCR. So once you have implanted the IOL, it's always better to check the integrity of the wound, whether it's leaking or not. You simply put a gentle tap on the center of the cornea or the limbus diametrically opposite and see the tension strength of the ACN wound stability. If any chance you find that wound is leaking, then it's always better to suture. Indications with suturing will be a leaking sclerocorneal tunnel, premature entry and buttonholing, severe positive pressure, myopic and pediatric patients because they have thinner sclera and lower scleral rigidity. Combined surgeries, obviously you do suturing. In case of PCR or vitreous disturbance, it's always safer to do surgery, to do suturing. And if you have a bigger tunnel, suppose you have done a superior tunnel and patient is already having high against the rule astigmatism, it's better to suture so that the surgically induced astigmatism is taken care. Now there are different studies which done to show whether which one is the best, cross suture or vertical or horizontal suture. They found that astigmatism is more or less the same. You can combine manual small incision cataract surgery with trabeculectomy also. You can do inverted W incision and you use this incision for your trabeculectomy, or you can simply do your technique and then use Callis punch to take out the internal lip, and then you have to suture it. There was one study which compared the manual small incision cataract surgery trab with phaco trab, and they found there is not significant difference so far the pressure control is concerned. So a lot of studies has been done to compare the results of MICS with manual small incision cataract surgery with phacoemulsification. They show that the results are comparable. So there was one randomized controlled trial was done, which took eight studies were included and done in obviously in India, Nepal, South Africa, the countries where manual small incision cataract surgery is done frequently. And so far the best corrected visual acuity is concerned, most of the studies found no difference. But if you look at the uncorrected visual acuity, they found that 3 studies they found that more favorable outcome with the phacoemulsification, because the chances of surgically induced astigmatism will be more in manual small incision cataract surgery. They studied the cost, which they found that in phacoemulsification it was almost 4 times higher compared to manual small incision cataract surgery. But this study did not rule out any risk of bias. Okay, so there was one more study which was done, and that study post-operative day 1 they didn't find any significant difference in the uncorrected visual acuity. They also found that small incision cataract surgery had less corneal edema. Maybe the setting of the study was in Nepal, so they had more advanced cataracts. So that's why the SICS group didn't have that much corneal edema. Uncorrected visual acuity also at 6 months was not any significant difference between the two studies. So this study was again done to compare the two. They found that manual small incision cataract surgery has less corneal edema than the co-emulsification group. PCR was more or less the same in both the studies. This study was done in Nepal again, and they found some of the complications they mentioned, like 3.9% had posterior PC rupture, and scleral corneal suturing was required in very few cases. Iridodialysis, they found one of the complications which was there, decimated straping also. This was done in a tertiary hospital where this was done on ophthalmic trainees, and they found that the complication rate was manual small incision cataract surgery was higher compared to phaco. This shows that there is a definitely learning curve with this technique, and particularly for the beginner, you have to be very methodical in your approach. Then there was one study which compared different type of incision and the surgically induced astigmatism, found it were more in straight incision compared to prone, and inverted V incision has least amount of surgically induced astigmatism. Again, the superior group had more astigmatism compared to the temporal group in both the studies. There was one study which compared the endothelial cell loss between the two methods, and that was not significantly different between the two groups. Both the study has shown the same result. Then obviously the cost was more in case of phacoemulsification, was basically due to the fact that manual small incision cataract surgery is done with a rigid lens, and foldable lens is having more cost, and there is at the same time the maintenance of the machine, acquiring the machine and maintenance definitely have some cost. So in conclusion, we can say that it has become very elegant and efficient surgery, and the final outcome and complication rate is comparable, but although we have some advantage in phaco compared to manual small incision cataract surgery, if we just look at one factor, that is uncorrected visual acuity. Thanks a lot.
Thank you, sir, for this excellent presentation. We've covered each and every topic of SICS in great detail, right from the bridal suture to the nuances of the sclerocorneal tunnel construction, nucleus management, and all the topics with excellent videos as well. It was really helpful. I invite one correction that I need to do is Professor Kamaljeet sir's introduction. I forgot to mention that he's presently a senior consultant with Center for Sight in Prayagraj.
Then you didn't forget I didn't mention it because somebody sent my PowerPoint.
Yeah, I knew that, but
That was my
I
fault.
apologize for that. So now I invite Professor Kamaljeet sir to please share insights on small incision from your vast experience. Say a few words, sir.
Actually, whenever I teach a small incision cataract surgery, I always tell to my residents that you must make a little larger incision. We normally say that you have to make 6 to 6.5 millimeter incision, but you should not be shy in making longer incision. Because then the delivery of the nucleus becomes much easy, and you are in no trouble. Next day, your cornea remains transparent, and there is no other complication. If the tunnel is small, then the chances are that you will have PCR also in some cases, because you are trying to put your irrigating vectors in a small incision. Then you struggle a little bit there, and then have PCR, and then can even have a hydrodialysis or they dialysis. So you should make a larger incision. Initially, you can always go with a paralimbal incision and then gradually graduate to crown incision. So that you can do, and then for capsular access, what you have to do is that you have to make slightly larger capsular access. Because these days I find that residents fantastic consultation, but they are not used to doing small incision cataract. They make a smaller capsular access. So what I suggest to them is that you make slightly larger capsular access. For that, you can use a forceps, strata forceps for making a larger capsular access. Then the delivery of the test becomes much easier. And you have to simply do irrigation, lots of dissection, and keep your tunnel pressed backwards. So when you do this, the fluid keeps on going out, and you have no posterior capsular rupture during the hydrodissection. That is a very, very good thing. You'll find that one side of the nucleus will lift, then you can simply rotate it and take the nucleus out of the bag. And if you have a hypermature cataract or brown cataract, then if you are trying to make a smaller capsular access, even larger capsular access, then you might have a intracapsular cataract surgery rather than an extracapsular. Because then the cataract is hard and it is usually fibers are attached to the capsular access bag, and you might have problem in bringing the nucleus out of the bag. So you can do if you have done a smaller access, then you can make a relaxing incision at 11 o'clock and 2 o'clock, and then take out the nucleus easily. Or you can, from the very beginning, you can simply do a can opener technique, and the prolapse is the easiest when you do a can opener. And what I found is that you make a superior temporal incision. Perhaps we have done a study on corneal topography on astigmatism, and we have found that superior temporally, usually the steeper axis is there. So if you don't have the facilities of topography or the historic marker, then you can simply put a superior temporal incision, and that will create less of the astigmatism. So some of these things can be taken care of, and use of lots of astigmatism, as the speaker has already mentioned. Those are some of the points that can be taken care of and will come out fantastically well during your surgery. Thank you.
Thank you, sir, for those excellent points. We have a few questions. Subodh sir, if in today's world of phaco, femto cataracts, I'm sure majority of your cases also would be either phaco or flax. But any specific scenarios where you would choose SICS as the first choice?
Yeah, most of the surgeries I normally do is phaco, obviously, but still I think manual small incision cataract surgery has a role, particularly Indian scenario where you. I think every week I find one or two cases which I find they are more suitable for manual small incision cataract surgery, like a very advanced brown and black cataract and the cornea is not that healthy, the endothelial count are less, pupil is not dilating that much, and particularly in a scenario where your VR backup is not that available in your hospital, and also in a scenario where you find that your machine you are not having the access to a very higher end machine will be required in case of that type of cataract, and uh, and also in a situation where suppose a patient is having against the rule astigmatism of say around 2 diopter or 1.5 diopter, still I think that if you in this type of scenario, if you are doing a temporal SICS and instead of doing a phaco with 2.8 millimeter incision, which doesn't have much surgically induced astigmatism, you can still neutralize that astigmatism, and with a very safe and a surgery which doesn't increases your adrenaline so much. So definitely this surgery still has. Suppose one of the situation which I find it very useful. Suppose you are having a hyper mature cataract, and normally I try to make rexis first with side ports, and suddenly there is a Argentinian flag sign and everything. You don't feel that the rexis will be supporting your FICO. Still, you can safely convert to SICS and take this out
Right,
without.
excellent point, sir. Even I do that in cases where it's a complicated case, so I first make a Rexis and then go ahead and either do phaco if everything looks fine, or if the Rexis is compromised, or we get a feel of the nucleus as well when we do the Rexis, how bad the nucleus is, and will this patient do well with phaco. So the point here is basically a good SICS is always better than a bad phaco in complicated cases. Another question is, I think online we're getting, is a trial of MICS always warranted in cases of mature cataract, or SICS should be planned straight away?
So normally in suppose I have a mature cataract, I try to judge whether how hard is the nucleus, and
Yes.
yeah, on slit lamp, if I find the nucleus is very hard,
Mhm.
or if you look at the anterior capsule, you find there is a lot of fibrosis on the anterior capsule, and your endothelium is not that healthy. You don't have access to higher end viscoelastic, or the VR backup is not there.
Right.
I go ahead with the manual small cell cataract surgery. But
Mhm.
if I find the nucleus is not that hard, and I can, then I make the rexis first, and
Mhm.
if the rexis is good, then I go ahead with a phacoemulsification.
Right.
Also, I keep the higher end visco and the retina standby, three-piece lens standby. Then you can always go ahead with the phacoemulsification.
So prepare for the worst and hope for the best.
Oh, yeah.
Right, right. Um, and like you told, in cases of in compromised endothelium or Fuchs endothelial dystrophy, I think it depends upon the surgeon as well. If the surgeon would know their competence better than anyone else. So if you feel that you can do a good phaco, or if you can do a better SICS in such complicated cases, that is what one should adopt. Uh, great. Any specific scenario where you can't do an SICS and probably do a ECC in complicated cases rather than an SICS, sir? Or you can manage any case with an SICS?
I think last 2-3 years I had to convert the SICS into ECC. That was the situation where the nucleus was bigger than what I anticipated, and the tunnel size was smaller than what should have been a bigger one. So in that situation, I was trying to deliver the nucleus. It was not coming out. So I make side cuts on the pillars one side, and then took out the nucleus. So in a situation where I find that the nucleus is not coming, instead of struggling a lot, causing more trauma to the iris, posterior capsule, and endothelium, rather it's safer to release one or two pillars, and take out the nucleus, convert into
Right.
ECC. But obviously you have to suture.
Right. So both of you, so even Kamaljeet sir, Singh sir, both of you have been teaching in institutes for a long period of time. Some institutes are still teaching ECC in the beginning of their PG's training program. Should that ECC training become shorter now, or just a few cases in the beginning and then shift to SICS, because now people have to learn about phaco as well as now femto as well. So and more or less, is it? It's a controversial question, but do you think it is fair on the patients as well if we do an ECCE rather than an SICS, sir? Please, sir.
Yes, in our institute, we either do SICS or FACO. So our residents have not even seen ECC,
Right.
how it is done, and they many of these residents, they cannot apply good Teno monofilament suture properly. So they would not bury it, they would not put it at a right place.
Mhm.
So they learn SICS very quickly. And once you learn SICS, then it's very easy to switch over to phacoemulsification.
Right, sir.
So
Even,
that is the situation today. But in our time, we learned intracapsular, then we graduated to ECC, then came phaco, and finally came the SICS. And I always say that SICS is an advancement over phacoemulsification.
oh, right, sir. Even I did during my training, I did almost 1,000 plus SICS, and then I did my first ECC.
Yeah.
Yeah, but I feel
Because I went to AIMS, and there when I did a live surgery at RP Center, and when I was doing the surgery, the resident asked me, "Sir, what are you doing?" So I told him that this is a new technique which we have developed, and you either know ECC or still today in RP Center, many of these residents, they tell us that they do either ECC or phacoemulsification.
Mhm.
So
But I
it's a
feel
very,
the
very good
only
surgery.
scenario where ECC would be required would be a clear corneal phaco that you need to convert. So,
Yeah. There you can do it, or if there is a subluxated lens,
right, sir.
subluxated cataract, or there is like too much of tremulousness there, then you can make in microcorneas also. You can make there you need to make a larger incision, even from 3 to 9 o'clock. So there what you can do is that you can take out the nucleus easily through a ECC incision through the limbus. Don't try to do SICS in those cases, because nucleus is very big and cornea is very small. So you might injure the cornea, and that
Right.
can cause problems.
If you can
Those
do
are the
a very good
subtle-
SICS, switching on to ECC also would not be very difficult.
Yeah, it's not very difficult. Yeah.
Yeah,
Only thing is you take care that you don't put a speculum there in ECC. You apply two lid stay sutures, because if you put a speculum, then you might have too much of pressure and vitreous might come out. Because speculum is not that simple thing to put for ECC, because you are at the limbus, and there is little bit of pressure on the sclera and inside the eye. So that could be a problem. So I always tell, this is the biggest difference between ECC and SICS is that you put a speculum there. It's a closed chamber surgery, whereas the ECC is a open chamber surgery. So there you simply put two lid sutures, and one at lower lid, two at upper lid, and that will help you in taking out the nucleus easily.
right, sir. Subodh sir,
Yeah. One of the example I would like to give, one is that I was doing a temporal phaco under topical, and suddenly I realized that the axis has suddenly has extended to the periphery, and maybe it has gone behind also. So what I did in that case, that instead of converting to ECC, because I have already made the tunnel, I made a suture temporally and then shifted superiorly to make a tunnel there. So
Yes.
that can also be tried in a situation where you
Yes,
find that.
that's the best way. If you have made a phaco incision, you make another for SICS. Don't go through that. Don't extend that incision. It's
excellent
very
point.
light, and that should be done in most of the cases.
One question is on SICS in poorly dilating pupils, sir. Subodh sir, if you can.
Yeah. Actually, what I do normally, I make use this VR seizures to make micro sphincterotomy, because those sutures are very excellent to make sphincter. So I make multiple sphincterotomies, and then the pupil obviously dilates to a manageable level. So that is my for SICS I do.
Even we can do a bit of stretch pupilloplasty, and that also gives
Yeah.
a good dilatation. One comment on the YouTube channel. We are live on YouTube. Dear doctor, how can we deal with a bevel up keratome? I don't know. Not sure what the question is about. Bevel up keratome, sir.
I have no idea what develop keratome. Only thing is that okay, while introducing the keratome, I in a situation where you're struggling, then obviously anytime you can inject some visco into the tunnel, because
Right.
the basic idea is to take your keratome to the anterior most end of the tunnel. If you
Right, sir.
enter into the anterior chamber before that, then there are chances of premature entry and then
Premature entry.
yeah.
Right, sir. Right, sir.
Yeah.
Great, great. Any questions, Dr. Kanika, from your side?
Sir, like sir already told that once he's doing a phaco and if the rhesus extends, he converts to an SICS tunnel at a different location. I was curious if we can do the reverse, like if we are going through an SICS and we decide that let us just abandon the tunnel, there is buttonholing or some other problem, and can we shift to a phaco in such a situation?
So usually my SICS are the cases where I have decided that the nucleus is very super hard and the
Exactly.
endothelium is not that good.
In the first
So
case only, if you're doing an SICS, that means that you're not able to do a phaco in that case, right?
yeah,
That's why you are doing the SICS.
yeah. So suppose there is you are doing a superior tunnel and there is buttonholing. Anyway, you can always shift to the other location and do SICS from that side. That you have to do before entering into the anterior chamber. Always you can shift in superior also. But anyway, that may, suppose you have planned according to your astigmatism and you have planned for temporally, you can, if you are shifting to superior, always do from that side, and always suture in these type of cases, so that the wound is one side wound is not that healthy, and you can try.
ये हम एक चीज बताएं आप लोगों को अपनी फर्स्ट थिंग इज दैट यू स्टूडियो इको पहला काम तो ये है कि आपको इंसिजन बड़ा बनाना है दूसरा ये है कि हर केस में फेको नहीं करना और ये भी नहीं जरूरी कि हर केस में एसआईसीएस करिए मरीज का जेब देखिए अगर वो नहीं अफोर्ड कर सकता तो डू एसआईसीएस और यू कैन गिव वेरी गुड रिजल्ट्स विद दैट और अगर आप एसआईसीएस करते रहेंगे फेको भी करते रहेंगे प्रॉपर इंडिकेशन अपने बना लीजिए and you will be happy and you will always say Om Shanti Shanti and you will be happy.
One more question, sir. Kamaljeet Singh, sir, I would like to ask you. What about those cases where we have a premature entry and the iris keeps, if there's a floppy iris and the iris keeps trying to come into the tunnel and disturbs the entry and exit of all the instruments as well as nucleus.
So apply a
How
suture
to
there.
deal with that?
Immediately apply a suture. Immediately apply a suture. It could be a vertical suture. No need to put a horizontal suture. Apply a suture and make another, select another site for making the incision. So that can be done. Always apply a suture and just change the site.
Okay, sir. Thank you, sir. Subodh, sir, anything from your side upon the same problem?
Actually, the problem is that once this iris starts coming, whatever you do, it will it will increase. I mean, the iris become more and more floppy.
Other thing that can be done is that you do a small iridectomy there, and then you will find that iris will stop coming out. So the simplest thing is apply one suture. Even if you are doing phacoemulsification and you find that iris is coming out, apply a suture, select another site for incision, and do the surgery there.
I will,
And
Dr. Kanika, I will give one example that there was a patient with relatively small pupil. I tried to prolapse the nucleus. During that process, iris become very floppy. So the nucleus came out somehow, but iris was so floppy that all the time coming from the main port. So in that situation, I applied suture and then did the IA part from the side port using bimanual. And once then I removed the suture and then implanted the lens. So iris, the more you touch it, more it will create problem for you. So that is there.
Thank you, sir. Thank you, sir. And thank you, Kamaljeet Singh, sir, for all your brilliant advices. I think these should definitely help our PG students navigate through their SICS smoothly. Thank you, sir, for every advice of yours and such a nice, beautiful presentation.
I think with that, we can conclude. Thank you, Kamaljeet sir and Subodh sir, both of you.
Thank
And
you. Thank you, Kamalji sir. Thank you, Dr. Amit. Thank you, Kanika. And thank you all the participants.
Thank you, sir, for such a wonderful session. I would like to take this opportunity to invite everyone for the iFocus, physical iFocus that will be held from June 9 to 16, 2024 at Hyderabad. The registration is limited to 300 candidates. So we invite you all to do the early bird registration as it will be closing soon. Thank you, everyone.
good night.